While you're getting set, what I've announced and what I've asked all of the students to do is to get their computers out, have their note writer ready to go, have it open, ready to go, so that when we tell you to start, you can start working on a 10-minute note after we watch this encounter. But you need to have a piece of paper for notes. Just like what we're going to be doing is watching a video. It's me doing an encounter. You will be taking notes like you're the one interviewing. Okay? But then after we're done with the 15-minute encounter, you will have 10 minutes to write a note, and then we're going to show you the grade checklist to then grade your note. Okay? And I have not seen Yankton on. I don't know if they're having trouble connecting. Yankton, are you there?
We're here.
We're here. We had trouble connecting, but we're connected now.
Okay. I see Yankton. I see a Sam. Is that Yankton? Let me see if this plays.
No, somebody else did. Not me.
So Yankton, did you hear what I said about getting your laptops out? Have your note writer up, ready to use.
Yep, we're getting that ready. Still very loud.
Okay, so there's no... sound on this ball. There's sound. Nope. There's sound on the computer. Can you go grab my computer upstairs, please? That's docked. Oh. Try that. I'm Mark Beard. I'm one of the medical students. All right. Is everyone hearing that? Can everyone hear that at all the campuses? I see thumbs up. Was everyone able to hear that? Okay. So what we're going to be doing, I'm going to be playing a video. Okay. This is Mrs. Haynes. I'm going to say she's middle-aged. You create the age. Okay. I will give you her vitals. Let's just say she's afebrile. Her blood pressure's 130/80. Her temp's 37. Her pulse is 75. Respiration's at 16. Her pulse ox is 99% on room air. BMI is 30. Okay? All right? And she is presenting to the clinic for dizziness. So that's the information on your face sheet. Okay? Your job as you watch this video, and as I go through this, I'm doing this such that I would have gotten all the points on the OSCE checklist for the encounter. But the point of this activity is then to focus on the note after we go through this. So take notes just like you would if you were asking the same questions or doing the same things that I'm doing in the midst of this encounter. And then when it's done, we're going to stop, and you're going to have 10 minutes then to write a note, and we're going to grade it together. I'm okay. All right? So here we go. Here's the encounter. Take your notes, and then we'll stop, and we'll grade it. We'll work on the note and then grade the note after that, okay? Here we go. Hi, Mrs. Haynes.
Yes.
Mrs. Haynes. I'm Mark Beard. I'm one of the medical students working with Dr. Lindemann today.
Okay.
I wanted to come in and introduce myself. Get some hand sanitizer here. How are you? I'm working with Dr. Lindemann, and I wanted to come talk to you for about 15 minutes about what's going on today.
Okay.
And thank you for letting me be part of your care today.
Not a problem.
What's going on?
I've been having episodes of dizziness.
Mhm.
It's been going on for about 3 days. It comes intermittently. I've been nauseous. And 2 days ago, there was just a feeling of fullness in my right ear.
Okay. If it's okay, I'm going to be taking some notes as we talk.
That's fine.
Can you tell me a little bit more about your right ear and what's been happening with that?
It has a feeling of fullness to it, and things sound a little bit softer, but not horribly so.
Okay, so can you still hear from that right ear?
I can. Sometimes I'll switch the phone to my left ear to hear somebody on the phone, but other than that,
Okay.
it's not terrible.
And have you had any recent infections in your ear?
No, I haven't.
Okay. Anything that drains from the ear that you've noticed?
No,
Any ringing in the ear?
no.
Okay. And coming back to the dizziness for the last 3 days, can you tell me a little bit more about that?
I had bent down to pick something up off the floor 3 days ago and started to feel dizzy, and it's kind of like the room is spinning.
Okay. And how long does that last when that
It lasts
happens?
about half an hour.
Okay. And what do you do to kind of stop it?
I sit down and just don't change position. As long as I keep my head still, it doesn't feel so bad then.
Okay. Well, I can imagine that that's affecting you a lot. How often does it happen through the day?
Maybe 2 or 3 times a day.
Okay. And you say you do have nausea. Do you actually throw up with that?
I have not thrown up, just felt very nauseous. So.
Okay. And along with that, have you had any recent infections?
About a week ago, I had a cold sore,
Okay.
and that went away with Carmex.
You have cold sores a lot?
Not often, no.
Okay. Have you tried taking anything for this to prevent it over the last couple of days? Or? Okay. Has this happened before?
No.
Okay. I can imagine that that's really interrupting your daily life.
Mhm.
What are you most concerned about with this?
I guess I'm afraid if I have a head tumor.
Okay. Do you have is there a history of head tumors in your family?
Not
Or?
in my family, no.
Okay. Well, we can definitely, with the rest of the history, as I kind of ask some more questions and do an exam, we'll try to answer that for you. I can imagine that would kind of weigh heavy on your mind
Nerve-wracking.
if you're worried about that.
Yeah.
Yeah. Well, we'll definitely do all we can to get some answers for you here today.
Okay.
I know that you know Dr. Lindemann very well, but since you're new to me, can I ask you some additional questions about your medical history?
Yes.
Do you have any medical problems that you see your doctor for regularly?
I have high blood pressure.
Okay.
And I've had that about 10 years ago. That was diagnosed, and I take medication for that.
What medication?
25 milligrams of HCTZ and 20 milligrams of lisinopril.
And those medicines are working okay for you?
Yeah.
Your blood pressure looks pretty good today. It's a little bit high, but worried about some of these things.
Yeah.
I can imagine that's causing that. So. And you said 20 milligrams of lisinopril?
Yes.
Okay. Do you need those refilled today?
Not today.
Okay. Anything else that you take on a regular basis?
No.
Anything over the counter or supplement?
No, nothing.
Okay. And besides the high blood pressure, any other medical problems that you have?
No.
Okay. Have you ever been hospitalized for anything?
Nope.
Surgeries?
Nope.
Okay. So you still have your gallbladder and your tonsils?
I do.
Appendix?
All
Okay.
my parts, I want to keep them.
Okay. And you mentioned no history of like a head tumor in your family. Does anything else run in your family?
My mom has high blood pressure as well, and diabetes.
Okay.
And my dad passed away in 2000. He was 65, and he died of a heart attack.
Okay. And do you know what type of diabetes your mom has?
I don't. She's it was older. She was older in life when she got it.
Okay. And I failed to ask earlier, do you have any allergies to
No.
any medications? Okay.
No,
And you live here in Sioux Falls?
I do.
What do you do?
I work with my husband. He's a used car salesman, and I run the desk and the phones.
Okay. I can imagine the ear issue is not helping with that right now.
No, not really.
Okay. And everything's okay in your marriage and relationship?
Yes.
A couple more sensitive issues, but important. Do you smoke?
I do.
You do? Okay.
Mhm.
How long have you smoked?
I've smoked for 20 years,
How much?
a pack a day.
Can we get you to quit?
You can try.
Maybe something we can talk about after we get through these kind
Yeah.
of current issues of the dizziness. How about any alcohol use?
On the weekends, I like 3 glasses of wine.
Okay. Any other drug use, marijuana, cocaine, anything?
No.
And are you sexually active with your husband?
Yes.
Any concerns about sexual activity? Okay. Now I'd like to just kind of run a quick laundry list of just a number of things that could be going on, make sure we're not missing anything.
Okay.
Have you noticed any headaches?
No headaches.
Okay. Any swelling in the neck, trouble swallowing,
Mm-mm.
chest pain,
No.
trouble breathing,
No.
any belly pain?
Mm-mm.
You mentioned the nausea. Have you noticed any diarrhea or constipation?
No.
Any rashes anywhere on your
No.
skin? Any numbness or tingling in your hands or feet that you've
Mm-mm.
noticed?
No.
Any trouble urinating?
No.
Okay. If it's okay, I'd like to do an exam.
Okay.
Okay. Let me help you up to the table here. I'll pull this step out for you. I put a sheet here for you. I'm going to get some hand sanitizer again. First thing I'm going to do is just look at your ears, if that's okay.
Yeah.
TMs are clear. Here. Very good. If you could look straight ahead, I'm just going to shine this light in your eyes. Perla. Everything looks normal there. I'm going to look in your nose. No boggy mucosa, no erythema. And then open up real big, stick out your tongue, and say, ah. Very good. Normal. And while you have your tongue out, can you move it to the left and to the right?
Shift.
Very good.
No erythema, no
Everything
ectatic.
looks normal on your exam there. Can you hear this?
Yes.
Can you hear this?
Yes.
Does it sound the same?
Yes.
Okay. I'm going to test your hearing just a little bit more with this tuning fork, okay? I'm going to place this on the top of your head if you could tell me where you hear it the most, okay?
It's about the same on both sides.
Okay, okay. I'm going to come to the right side here. Can you hear that?
Yes.
Tell me when you can't hear it.
I don't hear it.
Hear now?
Yes.
Tell me when you can't hear
I don't hear it.
it. Okay, let's try the other side. Same thing, okay? Can you hear that?
Yes, I can.
Tell me when you can't hear
Can't hear it.
it. And then here?
Yes. No, I can't
Okay.
hear it.
Okay. All right. I'd like to do a little bit more of a neurological exam. You mentioned your concern possibly about, could something be going on in the head. So let's do a more of a full neuro exam, make sure we're kind of looking at that as
Okay.
well. First thing I need you to do is follow my finger here, okay? Without moving your head. Very good.
Extraocular movements are all intact.
Any double vision aside from that last part that you noticed? Okay, okay. And we already kind of assessed the hearing there. Does this feel the same
Yes.
on both sides?
Yes.
Down through here?
Mm-hmm.
Bite down, show me your teeth. I noticed you have a little bit of a droop on that right side. Is that a new finding? Or?
No, I had Bell's palsy a long time ago.
Okay, so that's not anything that's changed?
5 minutes left.
Okay, okay. Can you smile, show me your teeth as best you can then? Okay, close your eyes, don't let me open them. Very good. Push against my hand and over here. Shrug your shoulders. Very good. Okay. You squeeze my fingers, pull me towards you, push away. Lift this leg up, over here. Kick out and pull back. Kick out, pull back. Good. Everything is checking out healthy and normal, so that's a good thing. So we're going to just check some reflexes here. That works. Okay. You just relax your legs here. And then just bring the sheet up just a little bit. Good.
Reflexes are 1+ in the upper extremities and symmetrical, 2+ in the lower extremities and symmetrical.
And does this feel the same on
Yes.
both sides? Here
Yes,
and here?
yes.
Okay. And you mentioned no numbness or tingling anywhere. Okay. A couple of just silly questions. Do you know where we are today?
We're at the clinic.
Okay. And do you know the day of the week?
It's Monday,
Do you know the date?
March 16th, 2015.
Do you know the season?
It is spring.
Okay,
Hopefully.
we just changed. yeah.
Hopefully.
Okay. And do you know who the president is?
Obama.
Assume she knows the right date.
I need to, if it's okay, just look at how you're walking as well with the dizziness. I'm going to set this down, if you'll step down. And if you could just walk to this corner over here. And turn around, walk back kind of on your heels. And then on your tiptoes. Very good. Okay. You can, actually, before you step up there, arms out to the side. Close your eyes for me. Any dizziness as you do that? Any sense that you're going to fall? Okay.
No.
Go ahead and have a seat up here. And could you do this for me? And on the other side? Excellent. Now, one of the things that, based on your story, that I think we need to look at, sometimes the inner ear can have a problem.
Okay.
Okay? So what I'd actually like you to do is kind of look over towards that corner, and I'm going to help you kind of fall back. Okay? And I actually need to be on this side. Keep looking over on this corner. Go ahead and come back. I'll bring this out for your legs. Any dizziness
No.
as we did that?
Mm-mm.
Okay? Now if you could look over to this side. And keep looking in that direction as I help you sit up here. Any dizziness there as we do that? Okay. All right. I'd like to just listen to your heart and lungs real fast, if
Okay.
I could.
Yep.
Down. Couple big deep breaths. Good.
Lungs are clear.
Good. Now just breathe normal. Gonna just untie your gown here. Just drop this shoulder so I can listen to your heart.
Regular rate and rhythm, no murmurs, no gallops, no rubs.
Good. Everything sounds normal. Let me bring this up for you here. Okay. Well, thank you very much for answering my questions. You know, I can imagine, I can definitely understand why this dizziness is a concern for you. Good news is that on exam everything's looking normal.
Okay.
And so that would make me think less likely that this would be a stroke or a tumor.
Okay.
Now that being said, I'll express that concern to Dr. Lindemann and we'll consider whether or not any imaging needs to be done in the future, okay?
Okay.
But probably more so I'm concerned about something going on in what's called the inner ear.
Okay.
There are little rocks in the inner ear that if they get moved around, they send signals to the brain that you're moving.
Okay.
And that's what often causes even motion sickness, okay? Because
Okay.
our eyes see we're moving and our ear says we're not moving.
Okay.
And so the inner ear can make us feel really dizzy. Two things, Meniere's disease is a condition of that inner ear that I think we need to look at. Also, one of those rocks can get loose and it causes what's known as benign positional vertigo. When you
Okay.
change position, it causes that spinning sensation. But I worry about Meniere's because it can cause that fullness in the ear as well. So I would like to just talk to Dr. Lindemann about that a little bit. I think there are some medicines that we can use to help you, but at the same time expressing your concern about the stroke or the tumor and making sure we're covering all of our bases.
Okay.
What questions do you have for me?
Nothing, you touched on it with the stroke, so.
Okay.
I don't have any
Let me help
more.
you down to the chair, and I'll step out and talk with Dr. Lindemann. Again, I thank you so
And
much
patient encounter.
for your time, and I'll be
Thank you.
back in about 10 minutes, okay? Thank you so much. Get my notes here. All right, those are my notes. Can't read them. Dan knows how I write in clinics, so you can't read my notes. You leave the room, you go to the computer here in the Perry Center. You guys have 10 minutes now to work on a note, okay? Go. Okay, we should be at 10 minutes. Your 10-minute count on your note writer should be past 10 minutes. So really be honest with yourself on where you hit 10 minutes, and ultimately the Perry Center staff and the proctors in the hallway will tell you all to step away from the computer. You can't just keep typing, okay? So you'll have to step away at that 10-minute mark. A couple of things, just remember that, in this encounter, there was a lot that had to be done related to the neuro assessment and then the HENT assessment. But if you do finish early, those minutes or that time gets to be added on to you working on your note. Okay? That doesn't mean try to rush through your history and physical and your assessment to get extra time to work on your note. You still have to pass the encounter as well. Okay? So let's take a look at this. I want you to keep track of your score as we go through this. Remember that another thing in the OSCE, the individual grading your note is not the same individual who watched the encounter. So all they have is your note. They do not have the ability to say, oh, I'm going to give Keegan the benefit of the doubt. I know he asked this, even though he didn't document it. Spencer?
Do you have to write in complete sentences, or can I just write fragments of?
You can write with bullets and fragments. That's okay. Yeah. You do get a point, and we'll go through this. You get a point for organization and clarity of note. And you will lose a point if you have a lot of spelling mistakes or if it's just kind of jumbled around, okay? So let's work through it. Everybody's laughing about spelling mistakes when I said that, okay? Let's go through this and give yourself points as we work through this, okay? So first thing, if I was grading this note, I would look for your note. I would look for CC or something as the title of having chief complaint and dizziness. If you don't have it, you don't get the point. If you just go to HPI, you don't get the point. In your HPI, somewhere you have to have 3 days duration. Okay, happening when changing positions. Unsteady on feet but not fallen. 2 days ago, noticed decreased hearing. No ear pain, no ringing. Fullness in the right ear. I can make this bigger. I see people squinting here. Nausea without vomiting. No headache or head injury. Those are the elements that get points on the HPI. So that's a total there of 8 points you could have gotten for chief concern, or 10 points for chief concern and HPI. Okay? Past medical history. No recent illnesses, but did have a cold sore on the lip a week ago. Chronic illnesses, hypertension. So you would need to have both of those for those points. Yes?
Since the history is kind of all one block, as long as it's somewhere in that block. So let's say someone put the cold sore in the HPI part, because that's where that was mentioned during actual history.
Sure. So the question was, if you put the cold sore in the HPI, would you get the point? Grading the note, I would give you the point. Okay? If you chose not to put that in the past medical history section. But it's got to be somewhere in the note. The easier you can make it for the grader to find the information, the easier it's going to be for them to give you those points there. Okay? You notice that there's no social or surgical history. Okay? This is one of the frustrating things for the students about the note grading forms. Okay? You notice here that we don't have any points for surgical history. Okay? That's purposeful. The encounter gives the points for asking about the surgical history, but the note may not. Okay? But there might be another note grading form later on for another encounter where we require that you have the surgical history there and you get the points.
You wouldn't be docked for including it.
I'm sorry?
You wouldn't be docked for including it since it's not.
You would not be docked for including it. So you need to follow the same process. But this is where students get really frustrated with the note because they want a set method for each note to approach it. And there's always a little bit of variability from one note to the next on how the note is being graded. Okay? Social history, if you documented the smoking, 20-year pack year smoking history. I think she said 3 glasses of wine instead of the 6-pack of beer. As long as you documented the alcohol, you get a point, and no drug use or dependency, you get a point.
I was going to ask about the next one. If the family history doesn't matter, why is the surgery not beyond?
So family history, non-contributory. Again, this is where we're finding certain things related to this. Family history was elevated out because of her patient perspective concern and the need to ask about that, and that there were no cranial malignancies in the past related to her patient perspective and concern. So it was elevated out by the OSCE committee on this case. Again, this is why students get frustrated with the note grading, okay? And this is why we have half the class remediate notes, because there's not a set best way to approach each note, okay? And this is the same with Step 2 CS. Spencer.
Why? It's obviously a systemic problem if 50% of people aren't passing. So why is it being blamed on us and not you guys?
It's not I don't think it is a systemic problem. It's an issue of us getting students to recognize needed appropriate information that needs to be in the note, and our students are passing Step 2 CS when they take the time to come back and look at their note. The systemic problem is that your faculty are not modeling the appropriate way to do a note.
Dr. Beard,
Okay?
do we get points if we put the family history in there, or do we need to put non-contributory?
Yeah, so as long as you've got family history, you would get a point. You don't have to state non-contributory. Medications, you need to have the hydrochlorothiazide and the lisinopril, and no allergies would give you both 2 points.
Do you need the dosage?
You need to have the dosage,
And the daily part?
at least the dosage. Okay? Vitals, I gave you kind of just some made-up vitals. You need to at least have the vitals in the objective section. If they're not there, you don't get the point. Okay? And I didn't give you this, so let's just say that it was listed on the face sheet, no orthostatic changes. You would all get the point there. Okay? Physical, you need to have somewhere on your physical lungs, that lungs were clear, heart, regular rate and rhythm for a point, that she was alert and oriented, that cranial nerves were intact. She didn't say this, but as long as you mentioned the hearing, you would get the point. She didn't mirror this as well, but Weber and Renee were both normal on hers. Strength was 5 out of 5. Cerebellar testing was intact. Romberg was negative, and gait was normal. All of those are points on the note.
Like, to me, that, I mean, so you're saying for the neuro exam, be as short and sweet as possible? Because, like, in a neurology actual H&P, that wouldn't suffice.
You need to document the tests and at least the findings. Okay?
To be short and sweet.
Yeah.
Yeah.
What was that? Yeah, that was a finding specific to that SP, so I had to kind of explain that if in the video somebody happened to see that she had a little bit of a facial droop, I just commented on that. It wasn't specific to the case, so it was just something she offered there.
So is there is it putting what's pertinent and what isn't? It's so always include neuro, cardio, respiratory?
No. So the question is, do you always include neuro, cardio, and respiratory? I would say probably knowing the OSCE cases over the last 3 years, you probably always should include cardio and respiratory. The other cases are going to be tailored to the presentations. Okay, so if it's a GI complaint, I want a more comprehensive gastrointestinal exam. If it's an HENT complaint, more comprehensive HENT exam. Okay, but probably on all cases, you want to auscultate the heart and lungs.
So you could have cases where you only have 3 physical exam sections.
You could.
Okay.
Mm-hmm. And then similarly, we have cases, not today, but at the next practice OSCE session, we'll do a counseling case where there is no physical, but you still have to write up a note. And there may be some objective findings a test that the patient has that's been done previously, or some lab results that have been done previously that you need to include as objective findings. Okay? And you still write those up in the note. The way that the note is always set up as well, you get more points for having the appropriate first diagnosis. So differential diagnosis 1, Meniere's disease, you have to list for that one 2 history findings that support it, at least 1 physical finding that supports it, and it needs to be listed as the first diagnosis. You can see this is 4 points here. So if you just wrote Meniere's disease and didn't have any supporting evidences as to why, you would lose out on those points.
What if your patient didn't have the decreased whispering or decreased hearing to whisper voice? Because she said
She did not. She did not have that, but at least listing for your top diagnosis, follow the pattern of having 2 history and 1 physical exam finding that supports why that is your top diagnosis.
So what was her physical exam finding?
For her?
Yeah.
So for her, I would probably say that she was just, you could just say the dizziness and just leave it at that, okay? In this case, she didn't have that in this video, and I think that was a mistake as we were recording that she needed to provide that finding.
Sure.
Okay?
So if you listed benign positional vertigo as the first diagnosis, then you get 0 points.
So the question is, if you listed benign positional vertigo as the first diagnosis, would you miss out on this point? Yes. Now, that's where we as the OSCE committee have to try to make sure our SPs are trained and are portraying the case exactly as they're supposed to, and that the students are given all the appropriate information to lead them to that top diagnosis. Okay? But this is an example of where points get missed. Okay? I don't want to get in an argument with you guys right now. I'm trying to make you aware of how this is set up so that you can start preparing now, because practice OSCEs for Yankton, practice OSCE is October 3rd. They're going to start working on practice OSCE, then Rapid Cities later in October, and then Sioux Falls will have their practice OSCE the end of October. Okay? Differential diagnosis 2 or 3. Usually we end up adding 2 or 3 more diagnoses to this based on what students come up with or how things are being portrayed. We talk as faculty about whether or not we allow certain things. We also decide to not allow certain diagnoses. But here on the answer key, benign positional vertigo is listed, and then labyrinthitis or vestibular neuritis was listed as the 3rd diagnosis. And you've got either history or physical findings supporting it for a point on each of diagnoses 2 and 3. So you can see where differential diagnosis 1, you need to have 2 history, 1 physical, but then for differential diagnosis 2 or 3, you need to have at least 1 history or physical supporting the reasoning for those diagnoses. Okay?
You said or, correct? So 1 history or physical.
Or. Workup and management, I would probably argue against the audiological evaluation a little bit here, but you would get ENT referral, Dix-Hallpike maneuver, Epley maneuver, steroid therapies, appropriately concise opening statement, and then having it organized with some headers would award you an additional 2 points. Yes, Dan.
Just as an example in this one, you did do the Dix-Hallpike maneuver
Yep.
already.
Mm-hmm.
So referencing that, is that...
So if that was in my physical, the grader would probably give me the point for the Dix-Hallpike.
So that in case, for future reference, if
Yeah.
you know, what would be...
So if you already do something that's in the plan and you document that in your objective, we as graders will give you that point if you don't have that in your plan, because you've already taken care of that. But this is where you may offer sensitive exams that you wouldn't have done in the midst of the OSCE, a rectal exam, a breast exam, a pelvic exam, because you're not going to be able to do that, but you should communicate that you want to do that with your attending, and when you come back in, you're going to do that and then put that in your plan. Okay? Spencer.
So is there any benefit for me to actually do any special tests, or should I just say I want to do those special tests later?
Is there any benefit to doing special tests that you can do in the midst of the exam?
Why would I do Dix-Hallpike if I can just put I'm going to do it later?
I think keep in mind that on this case, it was set up such that you could offer the Dix-Hallpike as a special test. For instance, on this case, they decided that you need to do the Weber and Rene testing in the midst of the actual evaluation. Okay, so there's going to be differences in encounters where it may be appropriate for you to try to do that if you have the time to do those special tests.
Should I always consult specialist?
Should you always consult specialists? No. Not every case has a specialist consultation. You are not going to get in trouble for it, but it needs to be appropriate. If you're offering a consultation, it needs to be appropriate. If the OSCE case is a case that should be managed by primary care, and you're consulting cardiology or consulting ENT for something that a primary care specialist should be able to manage, then you probably need to not consider that, okay? So this is one of those situations where in Step 2 CS, we have to recognize that, and you guys will see this when you work through first aid, many times in the plans, there's something there that you're going to say, there's no way that we would order that first line. But it's always listed like 4th or 5th in the plan, where it's an imaging study or a consultation or an additional next step, because you're thinking about what your differential diagnosis is. The best thing I can tell you to do is look at your differential diagnosis and say, for each one of those things, if I'm considering that, what might have to happen for that patient to be cared for, okay? And so specifically with Meniere's, benign positional vertigo, that probably doesn't need to have the consultation. Labyrinthitis, similarly, may not, but it's not going to resolve quickly. And so many times these patients do end up consulting ENT or neurology for the persisting dizziness. And it may end up that they have to have later on down the line imaging if it continues or persists. There are times that patients with these conditions end up needing to seek out those services. Okay? Kayla.
So just to be clear on the differentials, so if you, like, say you have all 3 differentials and they're supporting information, but they're just in different orders, then you just miss out on all the information?
No, you would still get points. So let's say if I had benign positional vertigo first, Meniere's second, and labyrinthitis third, I would still get all of the points for benign positional vertigo, okay? But keep in mind that if I focused a little bit more on that and gave a little bit more history and physical and not on the Meniere's, I might miss out on some of the other findings here if I didn't have both of those things listed under Meniere's disease.
Okay, but you would still get the, like, even if your differentials are in the right order?
If the differential's in the right order and I don't have the supporting evidences.
Other way around. If you have all the information, it's just not in the right order.
If you have all the information and it's just not right in the order, you'll miss probably just this 1 point for not having Meniere's listed first. Okay? Yeah?
I know this is just one specific example, but like say you prescribe something that, like something for vertigo that isn't listed specifically on there.
Yep.
Like, is that up to the grader or do you talk through it?
We would talk through it. So if I saw that, let's say, so the question is if I, in my plan, had something not on the checklist, and let's say I'm grading it, and I start out on Monday morning, and 3 of the students working through this case all want to prescribe meclizine as a nausea medication or for dizziness. I would probably reach out. I'd say, I'm noticing that students are regularly prescribing meclizine as part of their plan. Dr. Hearns would make note of that, and then we would probably continue to watch that through the afternoon. If it is a consistent thing, then we at that time make a decision and award that point. Okay? So we look at similarly if we find, for instance, where a case is supposed to be right upper quadrant pain and the students are more commonly documenting epigastric pain, then that triggers me to go back, and I, for Dr. Hearns, will go back and look at that video, or I'll start watching that SP and say, is the SP giving the information wrong or leading the students in a wrong way? And we go back and give those points, okay? So we do try to be very thoughtful with how the information is being given, and we have a lot of discussions over the Monday, Tuesday, and into Wednesday morning before we finalize the grades related to the OSCE. We want to be completely fair to you. But similarly, we don't give points for therapies or things that we all agree is not appropriate.
Yeah, you can't just throw anything back.
Yeah. Okay. Here, passing would be 31 points out of the 44. Okay. So I don't know, as a show of hands, how many of you would have passed this note here in Sioux Falls? Got maybe about half. Okay. This can be kind of eye-opening to students when we start talking about this and working through this. One thing that you've got to at least make sure you've taken care of is the efficiency. Okay? You've got to be able to write up a note in 10 minutes. Okay? The other thing right now, you just wrote this note seated. Downstairs, you're standing. Down in the Perry Center, you are standing. You're standing for the notes. If you're really tall, you might, I know one year we had a student bring a box because they wanted to raise the laptop up a little bit so they didn't have to be scrunched over typing on the laptop. You're aware in the Perry Center where those computers sit and kind of how high those are. So if that's something you feel like you might need to do, that's something to consider. Okay? Other things to remember is that this was just one note. Okay? In the midst of the OSCE, and this is not the most up-to-date document here. This is the document from last year, and we'll update this and release it to the class. Okay? But this is a 4-hour test. You are assigned during OSCE week for either a Monday AM, Monday PM, Tuesday AM, Tuesday PM, or Wednesday AM session. And you're doing encounters and notes for 4 hours. Step 2 CS is a full day of this type of testing, encounters and notes. So you need to have and build up a stamina to that and be able to work through that. The exam is 7 encounters. Each encounter is 25 minutes. And we're hopeful that you won't have to have a break built in, that we'll have enough groups based on the student size, the class size, that we won't have to build in a break slot to work all the students in, okay? But you've got to average 75% across all the stations to pass the encounter portion, and then 75% across all 4 notes to pass. So when you don't average 75% across all 4 of your notes, that's when students have to then remediate the notes. Okay, students miss out on points because they forget to wash their hands. Okay, communicate to the patient that you've washed your hands. Take good notes. Okay, remember that if you don't document it in the note, you didn't ask it. The grader of the note is not going to go back and watch the video and say, oh, Ryan, he asked about surgical history, he just didn't write it. Okay? Generally, you want to kind of work efficiently, get through that, review the SP checklist. We've used the SP checklist. Every practice OSCE. Those are 10 easy points you should get in each encounter. Asking about getting to know the person, and maintaining their modesty. Asking about, I want to make sure you're comfortable. Can I give you this lap sheet for your comfort? Check. Move on. Build those questions into your template, how you talk to the patient. They're easy points, and they're easy points for every encounter that you do in the OSCE. Okay? Focus on patient comfort. Patients are probably going to ask you a challenging question or concern. So in this encounter, it was the question about, could this be a brain tumor? I'm worried about that. Okay? Remember that if you have a diagnosis, you should have a test in your plan to evaluate for that particular diagnosis. Okay? Don't get too narrow too quickly. Try to think of 3 or 4 diagnoses and use every amount of time you have to review and think about diagnoses and plans. We'll talk a little bit more about this as we get into the OSCE. But when you show up for the OSCE, you get handed a clipboard. And in that clipboard is every face sheet for the encounters for the day. So if you finish a note a little bit early, start looking through your clipboard. Start making notes on things. Work ahead. Okay? All right, you have everything there that's going to help you begin to kind of think about the next case. Don't wait until you're standing in front of the door and they say, you may now enter, and then look at that face sheet if you've got a little bit of extra time. If you complete your note early, work on the quality of the note. take that time and try to improve that, work on the efficiency there. Okay? Spencer?
Are points always going to be equal between
No.
medical, physical?
No. They are not always equal between history, objective, subjective, objective plans, and they're not always equal from one encounter to the next.
Okay. So it doesn't make sense to go to something first.
Nope. Nope. Yeah. Yes.
Just, this isn't like a plan or anything, but what does remediation look like?
Remediation. What the question is, what does remediation look like? It's a pretty easy day. It's Thursday of OSCE week. So if you get the news on Wednesday that you've passed, you're done OSCE week. But if you have to remediate, you're there Thursday morning and sometimes into Thursday afternoon, depending on the number of students we have to remediate. Encounter remediation, students who have not been able to successfully pass the encounters, that's almost consistently Thursday afternoon because I'm the one that commonly does that with the students for the encounters. We very rarely have had to go into Friday. That being said, if we have a winter weather event that week, this is in February, it delays everything by one day. And so then we're looking at remediation on Friday. So do not plan a flight or a trip or a family vacation on Thursday or Friday. You know, we had one year where a student was well aware of this schedule and the requirement, and they came to me and said, I have a wedding. It's my brother's wedding, and I had to say no. And this student had to remediate. And I said, you got to take your chances there, but they were there for remediation. So you've got to not plan on those things during that time. For documentation, students miss out on a lot of points because they forget vitals or they don't document the objective test. Make sure you look at your face sheets. If there's a pregnancy test there, you've got to document it under objective. Write the vitals down, include those things. If you want a more invasive exam, okay, then offer that to the patient. Sometimes the patients may have a card, sometimes they don't. And don't always assume that the patients are going to have a card. I know you guys have gotten into the pattern of that in Pillar 1, and with the OSCEs, you'd like say, I might maybe do a breast exam. I don't know if that's important, hoping that they hand you a card, okay? I mean, be thoughtful, consider the exam, offer the exam that you think is appropriate, okay? And then don't just start throwing out exams because they're handing out cards. Oh, well, if we're doing a rectal exam, I might as well do a pelvic exam too. Okay, don't just assume that. Be thoughtful, be considerate of the patient. And if they don't hand you a card, don't ask them, say, do you have a card for me? Okay. Remember the primary diagnosis, we talked about that. Listing that first, 2 history pieces and 1 physical exam, and then second and third diagnoses. I would encourage you to always try to get 1 history and 1 physical on each one of those. This last checklist had either or, but I would just get in the habit of always trying to have 1 history and 1 physical exam finding there. Other things just to make you aware of for the OSCE, and then we'll break here and go to our practice OSCE for today. But there are some encounters that you will not have a lot of opportunity to practice in Pillar 2. One of them is a blended encounter, okay? So the students, let's say you're assigned to Monday a.m. Half of those students will be going down the orange hallway in the Perry Center. The other half will be down the red hallway in the Perry Center. At some point, students rotating through that hallway will come to the high fidelity rooms where we have the SimMan 3G mannequin. That's what we call the blended encounter, okay? The blended encounter is an encounter with another student. You are graded together. You both get the same grade. So if one of those students doesn't wash their hands, both students lose the points for not washing their hands. Okay? You interact together. You interact with the mannequin and the SP that's in the room. Usually it's a family member. Okay? It's not a wrong thing as you're asking the mannequin questions to say, I can see you're in a little bit of distress, or I can see you're having a hard time answering my questions. Would it be okay if I ask your family member the questions? And sometimes that can help with efficiency, okay? If you have the mannequin having a lot of pain or having a lot of trouble breathing, okay? This is a 20 to 25 minute encounter without documentation. The intent of the encounter is that it's a more critical, urgent condition that you're going to ultimately take the patient from assessment to admission. You have the ability to order tests, order therapies, you can place oxygen, you can ask for x-rays, and sometimes that information will come up on the screen. You are used to this. You've done this in Pillar 1, you've done it in the high fidelity simulations through Pillar 2, okay? Remember, you have to put gloves on to work with the mannequin. So that's another thing that they want you to do there. Okay? So you have to care for the patient, not just diagnose the patient. Yes?
Will we find out who we're working with a little in advance of that day?
Will you find out who you're working with in advance of that day? No. You will have an idea the moment that you will know who's rotating, who is in that group, but you really probably won't know until you're standing in the hallway and you happen to look over and you see, oh, there's Spencer in the red hallway at the same door. I'm going to have to go work with Spencer now. Okay? All right? I would say generally, though, we usually pool students together in that Monday is often a travel day for Rapid City, where they're asked to travel in, so they tend not to end up doing OSCE on Monday. They end up doing it on Tuesday. Sioux Falls tends to favor more Monday for the OSCE exam, just because they're already here. And a lot of that is dependent on winter weather. Okay? The evidence-based medicine encounter is the encounter always at the end of the hallway. Okay, this is an encounter that's flipped. There's also no documentation with this encounter, but there's a quiz with this encounter. This is another one we're not practicing before, either in your practice OSCE or before the high-stakes OSCE. What happens is you show up to that door, you have a file with information about the patient. It already has oftentimes the diagnosis, and it's a diagnosis that none of you have seen. We assume none of you have seen it. It's a rare diagnosis here, such that you're going to have to look up information in order to counsel and treat the patient. Okay? So it's a diagnosis where you then have to go online, use evidence-based resources to look things up, learn about how to treat it, how best to treat it. You all have to take a quiz, which is intended to kind of standardize your knowledge set, so that you all at least know what information we want you to at least cover when you go in and talk to the patient, and then you go in for 10 minutes and counsel the patient about the diagnosis. Okay? I would encourage you to consider that if the quiz is asking a question, it probably needs to be covered when you're talking to the patient about that particular topic, and there's no documentation. And then finally, you have a practical skills station, and this is a station that will test your ability to read radiography, EKGs, and listen to the SAMs. Okay? Kayla.
With the evidence-based one, so are we given where to go, or we're just supposed to?
Many times we open it up to a page we want you to use. You can go anywhere you want thereafter. You do not have, I would remind all students that down in the Perry Center, we do not have computers that have access to up-to-date.
Can we use our own computers, did you say?
No. You use a computer provided by the Perry Center, and those computers do not have up-to-date. You do not have the time to log into Epic or Meditech and use up-to-date. So you'll have to use the resources. We'll open it up to a resource or recommend a resource we want you to use. Okay, that might be the CDC website, or might be a South Dakota website specific to the state with recommendations, but up-to-date often is not available.
We should be able to find everything we need on the website.
Yes. Yeah.
So to be clear, can we not use up-to-date though? If we have access
Yeah, we're in code.
Yeah, we can get online. It's up to date.
On the line.
On.
Yeah, if you can get on from a Perry Center computer onto up to date, then that's fine. Okay? Rapid City, questions? I know we've talked about a lot. Farm, questions from any of the farm students? Yankton, any questions from Yankton? Concerns? I know that this can be an incredibly frustrating activity for students. I'm going to do all that I can to prepare you and give you the tips and tricks to succeed and give you the tools to succeed, but you've got to invest a little bit of energy and time into practice as we get closer to the OSCE. I know that if you're not practicing the 10-minute notes, it gets hard if you're not used to typing efficiently in 10 minutes as you get closer to that. Use Step 2 CS, first aid, rely on that, reference that, practice 10-minute notes in some of your clinics. You know, it wouldn't be a bad idea to every family medicine clinic or internal medicine clinic do a 10-minute note once a week and practice typing one up and have somebody look at it, have somebody grade it. A lot of your clinicians have not done an OSCE. And so it's hard for them. You can give them a note and they can look at it and they can say, yeah, this is a great note. But that might be where you ask your education coordinators. I'm happy to look at them. You know, ask your faculty who are familiar with OSCE, is this a note that's sufficient that would give me the points I need for an OSCE encounter? Okay? All right. Sioux Falls, take a break, head down to the Perry Center. You guys have your assignments for the ID, HE, and T cases. We're going to try to build in another note practice downstairs with these rotations. So. Okay. Okay. So if you guys would just start with the one that she knows, and then we can have you watch another group. Yeah. Thank you, Rapid. Thank you, Farm students. You guys are good to go. Farm, you'll have to watch the videos. I've released all the documents to you, but you'll have to watch the HE&T video that we release and then practice writing up the note. And then the next practice OSCE will be a counseling case where we'll have you actually interview. Okay? Thank you, guys.